So I want to invite all the speakers to come up on stage. And we want you guys to come up to the mic. If you have any questions, we'd like to hear them.
Okay, so on the original slide that you showed us, there was one slide that had like the best day, and then marijuana was on there. And I was just wondering how the increased legalization of marijuana has caused, like how that's changed how the medical field views it and how they treat it if they feel that that's necessary.
I'm going to let the Colorado
I can
person
speak to
address
that. So it's tough, right? And I think it kind of falls into that same category as like tobacco and alcohol now, where it's legal, it's socially acceptable. So kind of the best discussion I can have with my patients is just giving them the information, although limited because we don't have great evidence-based data about it, but what we do know about cannabis and the long-term effects so that they can make informed decisions about their ongoing cannabis use. But it is very difficult because they're able to go to one of the dispensaries on the corner and purchase the cannabis just like alcohol and tobacco. So I think it's changed the landscape here in Colorado, definitely.
And I can speak to New Mexico being a medical marijuana state and working in a criminal justice setting. My patients aren't allowed to use marijuana because, and many of them have a medical card for PTSD and things like that, because we have about, it's like what, 14, 18 conditions that's approved? And growing, yeah. They're even considering it in New Mexico as a treatment for opioid use disorder, which I don't really understand, but anyway. So there's a delicate balance with some of these patients, and you have to be careful because when is it what we would look at in some circles as appropriate use, and when does it become a use disorder? So always keep in mind that DSM-5, right? You just change the substance, but the criteria always remain the same. Does that help?
Yes, thank you.
Hi, speaking to the statistic you mentioned earlier about being in recovery for 3 years and then try to get them to the 5-year mark, the 90% recovery rate, how do you keep patients engaged between that 3 and 5 year mark? Since, you know, by the third year, they're like, okay, I'm in a good state for quite a while now. How do you keep them engaged to get them to that 5-year mark? Does that make sense?
Well, it's a tough one. What I've seen in my own clinical practice is that the more supports that you have in place, so family is important, a job is important, housing is important, recovery programs are important. So there are things like SMART recovery. 12-step programs help for some people, and when they have a sponsor, that helps for some people. Staying away from their previous friends who used, that's a big one. And, you know, having that therapeutic relationship with everyone in that clinic system. And Matt gave great examples of all those people within that system that work. You have to have that trusting relationship. Now, you know, are people going to relapse? Remember, this is a relapsing and remitting disease. So as soon as that patient makes that choice to use, we want to scoop them up and make sure they get back on track again. But again, this is not a moral failing.
I have one last question. When you mentioned the incarcerated patient that comes to you straight out of incarceration, no shower, nothing, what's your first step besides basic education? What is your first step in getting them the help they need?
That's a really good question. So the first thing I ask them is I ask for permission for me to get a history. Sometimes they're not ready. Sometimes they just want to sit there and they want to kind of get their thoughts together. They don't want to talk. They want to hear from me what I can offer them. And sometimes they're ready to talk. But I always ask for permission. And many of these patients, that's what they want. Because, especially in a criminal justice system, they've been told and told and told again. So this whole idea of treating these patients with respect, treating them like they're human beings because they haven't been treating that way for so long, that's the most important thing.
Thank you.
Mm-hmm.
Hi. So I'm not sure if this is a problem everywhere, but in my community, I know that patients who are willing to seek detox often can't connect with resources, so they'll end up going to the ER and saying that they're suicidal even though they're not. How can we better connect these patients to the resources to get them the help that they want? Sorry.
So yeah, I mean, I think one of the things that is lacking is case management resources, and so I wish I had the time that Deb did to have that conversation. But I absolutely agree that the first step is to show someone respect. Luckily for us in our community health centers, we have community health workers and peer support specialists, which goes back to engaging folks that are, you know, at 3 years or 5 years and helping them become employable actually within our clinic system to help their peers. But case management services is a key. And I think within each one of our organizations, back to that, you know, we have a very fragmented system, but we have to start somewhere. And I think that that's something we've done. And how do we, as a community health center, engage our local hospitals to do the same, to accept the same type of model? There is another very interesting thing, and again, it's probably dependent on what community you're in, but in our community setting, we have a lot of vacancies of entry-level positions like tech jobs at the state hospital, our behavioral health hospital, entry-level positions that we can't fill or keep filled. And we have folks in recovery that need jobs. What a match made in heaven. And so connecting those types of resources, I think there are opportunities to do that, but it does take a we attitude.
To give you kind of the hospital perspective, anyone here get trained in SBIRT in your PA program? Couple? Okay. So screening, brief intervention, and referral to treatment. It's a evidence-based approach to trying to screen patients in the ER. The problem with SBIRT is the last part, referral to treatment. What do you do in a community where you have no place to refer these patients to? SBIRT kind of goes down the toilet, right? What's interesting to me about the systems of care that we have, at least in Austin in the outpatient setting, is that there's no other medical problem that I know of where you immediately get referred to specialty care, right? Surgery is a little bit different, but medicine, if you come in and you have a new diagnosis of heart failure, you don't usually go right to the cardiologist, right? If you have new diabetes, you don't go right to the endocrinologist, right? There's other places, there's other steps along the way. And so to me, yes, I completely agree that this is a systems issue, and if we're really going to solve this, we don't just need healthcare disciplines at the table, because I agree that case management is a very underutilized area, but like Matt mentioned earlier, we need criminal justice at the table, and we need, you know, judges at the table, peer recovery communities at the table, housing at the table, harm reduction. All of those different entities need to be at the table together. But within this room, within the walls of this room right now, we need all of those who work in healthcare to be exposed to this and be willing to screen and start interventions. Because just like any other medical problem, that's what we do. That's what we do. But this whole idea of drawing an analogy between this and diabetes and heart failure and other medical problems. And so if we had more places, so I'll give you a quick example. The program that we started at my hospital, the program that I run, it's an inpatient program. So to receive services from my team, you have to be admitted to the hospital. We did that a little bit backwards from what most hospitals do. Most hospitals start programs in the ER and eventually grow inpatient. We are doing this backwards. And so we are starting in the inpatient, and now we're going to the ER. My ER director is extremely supportive of this idea. Currently in our ER, we do SBIRT, and we just hope that they go to one of the 2 places in town that they can where the wait list is 30 days, right? That's not a good model. The reason why they haven't done more, his biggest concern is, I don't have capacity in the community. So if I have a patient that comes in and I want to train all of my ER docs, get them all X-waved and prescribing buprenorphine, I'll do that. But then where am I sending them? And I don't have a good answer for him. So that's what we need. All of you in this room need to get on board that, and that's how we increase access to care. And then all these other pieces fit in once we start doing that.
So one other thing with regard to your question. So if you don't have places to send them, at the very minimum, if you don't have the MAT, what you could do is call your State Department of Health and see what they have in terms of resources where you can send people. Call your local hospital and see what the discharge planner is doing in terms of referral sources. There's a buprenorphine treatment locator where you can find providers, the closest providers in your community. That's another place to go. But at the very least, you can try to find people who are doing drug and alcohol rehab in terms of therapy. You can look for 12-step programs. Smart Recovery is a great resource. Anybody familiar with Smart Recovery in the room? Anybody ever heard of that? It's an online program. And if you just want to write down smartrecovery.org, it has great resources. People can do it any time of day, day or night. And you can actually set up groups that you can do on your own. Here, when I used to work in Denver with Kaiser, we used to refer people to something called Phoenix Multisport. They have that in a lot of cities. So people who like to exercise but are in recovery, these are groups where you can go. If you're a runner, a swimmer, a climber, whatever, groups where you can go and get support from people who are sober and looking to continue in recovery. So I hope that helps.
Hi. You guys were speaking about the stigma and how it's extremely pervasive for a lot of these patients. And I was curious to know, when patients are in recovery and they face stigma, perhaps when they're trying to get a refill of their prescription at their local pharmacy, how do you best, in a sense, reset them? And then on the flip side, when we're with our colleagues and perhaps they don't necessarily have the mindset or are unaware of MAT, how do you start that discussion?
So I'll start with that. I worked at a place where there was a family practice provider who was very upset about the type of patient that was coming in for treatment and wanted them to come at a different time of day. And what I tried to do was help her understand that the patients that were coming in were the neighbors, relatives, friends of her patients, and that everybody needed to be treated the same because these are all chronic diseases. And I think she was just frustrated because there was one time where one guy went up to people in the lobby and was asking for a urine. So, you know, there's going to be challenges no matter, we work in medicine, and there's going to be challenges. So I think the more that we work with our colleagues and help them to understand that, again, this is a disease and not a moral failing. We're still, you know, on that trajectory. I think just with time and education, we'll get there. I don't know what else everybody has to say about that.
I'll just echo. So with our program, the only way that we were able to be successful doing what we're doing in the hospital is by educating all of our attendings and our clinical staff. And when we first started doing that, I think there was a little bit of, to a certain extent, I think there's some opioid fatigue in the medical community because it is the issue, and you can't go to a conference, you can't pick up a journal now and not have something about it. And so I think their perspective initially was like, what now, sort of? But I'll also say that at least in the hospital, and I'm very biased to the hospital setting. I've never practiced in the outpatient setting, so I'll add that caveat in there. But in the hospital setting, all of our clinical teams, nurses, physicians, everyone who's part of our care team has a tremendous thirst for a way to help these patients. There is nothing more frustrating than having a patient before you that you see all of the time in the hospital who you really have nothing, that you have nothing to offer them. And so part of, I think, that attitude and that frustration comes out of not being able to do anything. And so we framed this as, actually, there is something you can do. There's more than one thing you can do. And so that's how we framed Introduction to Buprenorphine. That's how we framed Introduction to Patient-First Language and Recovery-Centered Language. And that's how we were able. The other thing, too, is the thing that really helped us was patient stories. So when we started doing our work, we had early on a couple of patient success stories where these patients just did incredibly well after being started on buprenorphine in the hospital, and we really leveraged that to say, look, you can either continue running your practice this way and having these outcomes, which we all know are not great, or look at what we can do if we work together and start this medication, et cetera, et cetera.
Thank you.
Hi, sorry, I just had a quick question. So I've been noticing in Denver that there's a lot of people who have substance abuse disorders, just like riding the bus, and it's like the lack of social support and just like natural human respect they get from everyone around them is so sad. And when you have a patient that comes into the ER and they talk about how the reason why they do it is because they're worthless, they have like neglect, like no one wants, like how do you handle being able to send that patient back out when they have literally no one and no social support to help them?
Yeah, it's tough. So one thing that I try to do is I try to kind of meet the person where it's at, and even though I'm not gonna, there are some times where my clinical interaction with that patient has nothing to do with medicine. We talk about emergency shelters, we talk about clothing, sometimes we'll even grab clothes there, we'll talk about our RTD vouchers, just meeting those basic needs, and then also kind of providing that empathetic listening, because sometimes that patient, that's really all they need, is to feel like a human being, even if it's for 10, 15 minutes, and to feel recognized, because like you said, day in and day out, they're just kind of like kicked around like trash. So I think just being able to provide a little bit of support and kind of those basic needs in that interaction can maybe be enough for someone to maybe engage in primary care visits or make some sort of change in their life to maybe change the trajectory of their life. But it's really hard. I think the hardest thing about being a provider then in that situation as well is to not keep it all inside. So taking care of yourself as well and knowing that you only have so much that you can provide for those patients, and that there is a lot of systemic work that needs to be done, and if that means being an advocate in the system to change some of those behaviors within the community and within society, can be rewarding and then also helpful with these patients.
So there's another piece to what you're asking about, and I worked at a detox and recovery center where there were two hospitals in the same city, one doing exactly what Michelle is doing, where they provide MAT, and the other one that doesn't. So the one that doesn't is basically kicking patients to the curb. And the one like Michelle's is thoughtful and treating patients the way they deserve to be treated. So I would get patients in who had been treated inappropriately at an emergency room setting, and they already feel bad about themselves, but they're feeling worse because they've been treated terribly by a provider. So you already have somebody who's in withdrawal, they were looking for treatment at an emergency department, and they didn't receive it. And many of you are going to get patients like this at some point or another, and it's like, how do you manage that? So there's all these layers to substance use disorder treatment that we need to handle, and we have to do it one step at a time. It's challenging, but you've heard us all say it is extraordinarily rewarding, because what we're doing is we're not only saving lives, but we're giving people their lives back. We're giving people their lives that they never even imagined for themselves.
Can I just add one thing? So I've trained at all safety net institutions. I worked at a private hospital for a very short period of time after I graduated, and then I went right back to the safety net environment. And the kind of situation you're describing, I think, happens most frequently in a safety net environment, and not just around substances. I mean, these are often patients who have multitudes of medical issues for a variety of psychosocial, organic medical reasons. All of that said, I just want to kind of put this plug out there. It is so incredibly rewarding to work in a safety net institution. It is hard work. It's challenging work. You do have to know where your limits are and make sure that you know where those boundaries are. But I highly, 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 highly encourage you consider working in a safety net setting when you graduate. And I've done both. Like I said, it's a real privilege to be able to treat these patients where they're at.
So just one sentence, do what you can, and it's always enough. You know, especially with issues like this, when you're working in areas of disparity, it's easy to feel like, you know, that's just so overwhelming. There's so much. I'm just barely making a scratch, if that, right? But it becomes a mindset, and I think that's how you take care of yourself as well, is that you do what you can, and it's always enough versus it's never enough. It's the, you know, full side of the glass. And the more of us that do that, and that's the point of this, and you guys are huge, the impact that you guys will make, you know, it's literally immeasurable, just those of you in this room alone. And so if we throw our hands up in this room, yeah, we're not going to get very far. But if we do everything we can and we encourage others to do the same, then the opposite of that ripple effect can go a really long way, and it has to start somewhere, and it starts with you.